So here we are. Joe, you're undercover. There you are. Okay.
Good morning, Dave.
And welcome, everybody. This is Health Wonk Review on Air, number 2. And I hope it's the second of many. As I was just saying, I hope that all of you watching today will subscribe to the series, and that will give you automatic notifications of future editions, which will come up every other week at this time. Welcome, Joe. Welcome, Jan. We are talking today about the Health Wonk Review edition posted by Peggy Salvatore, who unfortunately is under the weather today, and may be joining us by chat or may not be able to. At any rate, the topic, some of the topics to be discussed today are pulled together by Peggy, and she called this the Early Bird Catches the Worm Spring Edition, and it's certainly springing around here. I have the usual New England effect of weather. If you don't like it, just wait a few minutes and something new will happen. At any rate, we have quite a selection of posts, and for those of you who are not familiar with the posts and Health Wonk Review in general, it's not only a blab, but it's a long-standing blog carnival, and I invite you all to check out healthwonkreview.com, which will lead you to the current edition of Health Wonk Review, and also to the blabs as they come up. So welcome all. And Joe, how have you been?
I have been well. It's 41 degrees and raining/sleeting here in upstate New York, a beautiful spring day. So if there are any early birds out there, they better have their feathers fluffed. Right.
Great. And Jan, welcome again. Good to see you. I am interested. I think a lot of the issues that we're looking at in this edition have to do, unsurprisingly, with payment innovation, payment reform of one sort or another. And Joe, is there any one of those that caught your eye that you'd like to kick this off with?
If it's okay with you, David, I'd actually, what really struck me about Peggy's edition was the lead, if you will, which was Dr. Brad Flansbaum's discussion of his interaction with pharma and how that evolved, or how that didn't really evolve. It proceeded apace for quite a while, and then he sort of had a seminal moment where he realized that maybe what he was doing wasn't in the best interest of his ongoing ethical foundation. So I was actually been looking forward to this discussion because I'd like to hear from Jen what his take is on sort of the physician pharmaceutical company interaction. You know, as a non-clinician, managed care operations guy, I have my own set of biases about this, but what was sort of compelling about Brad's post was that he was a hospitalist and was educating people and going to these meetings and thought it was okay. And then in a meeting with someone who was one of the marketing gurus for a pharmaceutical company, and he was actually invited into a sales training session for the pharmaceutical company's reps. And in the process, they had gone through some role playing, and he was struck by, okay, the person who was playing the role of the hospitalist was essentially saying, okay, it's a Me Too drug, I'm not interested. And then they replayed that, and they showed how the pharmaceutical reps should overcome those objections, as we sales guys say, and what they could do to convince the purchasing person, the prescribing person, to actually go ahead and prescribe a more expensive Me Too drug, even though the clinical benefit might not have been significant. So I'm not in any way, shape, or form suggesting that this is the way these things happen, or whether this is commonplace or whatnot, but that was Dr. Flansbaum's perspective, and I was really interested to hear what John's sort of history was in this whole pharmaceutical physician interface. John, what's your take?
I was less jazzed by this. This is a narrative. This is a story that us docs have been hearing about for decades. I know several colleagues. I think all us physicians do, who from time to time have been involved in sessions that are both marketing as well as educational.
Mm-hmm.
The tone of this particular post is more on the, oh my, pharmaceutical companies are out to make money, and that gets under my ethical skin. On the other hand, I think there are a lot of other clinicians out there who really regard this opportunity to educate physicians about use of a drug that works. There are other conditions out there where drugs really do make a difference in people's lives, and they don't really feel that badly about being personally compensated for that. And also at the same time, they're helping to advance the shareholders' value of all those individuals that invest in these companies.
Yeah, I guess what struck me about this wasn't so much that, okay, it's educating pharmaceutical reps to do pharmaceutical sales, which is fine. As a former sales guy and sales trainer, I get how that works. It was, I believe in the example, it was a drug that was kind of a Me Too drug, and it was trying to convince someone to use a drug that there really didn't seem to be, again, non-clinician's perspective, any inherent fundamental improvement of health status, etc. It was just, this was primarily and almost solely going to benefit the pharmaceutical company. So again, I don't want to misinterpret that, but if you're promoting a medication that's going to cure Ebola or Zika or what have you, that's great, and that's entirely appropriate. And I'm a for-profit guy. I've put 3 kids through college. I understand how those things work, and I don't work for free, and I'm sure you guys don't either. But you got to sort of deliver value. And the sense I got was that there wasn't a lot of value associated with that particular medication, and that was sort of where Brad was getting a little sideways. Do you think that's a fair criticism, Jan?
I think I agree. It is a fair criticism, but I'm not too sure that that what happened to Brad necessarily generalizes into the entire behavior of the pharmaceutical industry. But
fair point.
It is a very telling anecdote, and there are a disturbing number of anecdotes that are like this out there. This is an issue that needs to be better dealt with, I think, by the medical profession, and kudos for Brad for shining a light on it again.
Well, I appreciate you being willing to be on the hot seat. Not that I gave you a whole lot of choice there, John.
And this is certainly an issue that's been dealt with in a number of ways and through a variety of regulatory schemes, ranging from sunshine, along the lines of sunlight is the best disinfectant. Just shine a light on exactly what's happening and who's paying what to whom, and then people will be aware and can see what the incentives may be here, to more prescriptive regulatory schemes that limit the kinds of payments that may be made from industry to the professions, and the incentives that may be given, trying to maintain the independent judgment of the professionals, which the general public expects. And all of us, I think, expect and believe is there, except for the times when we see the light shone upon it so openly. I think we all have this sort of willful suspension of disbelief about things. I have this experience every day when I read the newspaper or some, simulacrum of a newspaper. The things that I know about firsthand, the newspaper invariably gets wrong in some important detail. But yet I read all the other articles and, tend to believe them because it's the news.
Yeah.
right?
Yep.
So, shining a light, I think, is helpful in sort of demonstrating the incentives at play is helpful. It doesn't mean that there's no prescription medication that's not helpful. There's certainly many wonder drugs out there today and over the years. So can't throw the baby out with the bathwater, so to speak.
Right.
Yeah. So if I may, as a segue, Joe, the financial issues at play in healthcare, the dollars in play are so large, so significant, that there are a variety of different things that we try to do with the dollars in order to influence people's behaviors and activities, whether those people are professionals or whether those people are patients, right? So once again, we are looking at that in the context of a Medicare initiative for CMMI, building on an initiative that has lasted for a couple of years now. This is something that you wrote about, Jan, in your recent post. The comprehensive primary care initiative. And now we're moving from comprehensive primary care to comprehensive primary care plus. And my understanding is that the first round has not been fully studied or examined yet. And to me, it seemed a little surprising to be rushing ahead into phase 2 at this point. And again, it's, at some basic level, some of the ideas sound good in general, but as always, the devil's in the details. I'm wondering if you could shine a light, if you will, on this initiative and what your expectation is of where it may be going.
Well, there's a perspective out there that if we can only help Medicare beneficiaries do a better job of accessing their primary care providers for both a more comprehensive, coordinated care that also has the merit of offering a somewhat lower cost level of service. And if we combine that with ongoing care management, this is usually a non-physician, usually providing coaching services to help persons be better stewards of their various conditions. So among persons with diabetes and high blood pressure and other lifestyle illnesses, that by helping persons be better stewards of their condition, that results in downstream dividends in terms of lower cost and higher quality. And there was the Medicare Coordinated Care demonstration, which was several years ago, and now the CPC Plus, which combined basically two elements. The first is care management, which was paid for by CMS and other insurers, and a robust electronic health record infrastructure with lots of data sharing. And the insight from Europe, for example, is that when you provide those kinds of services, that healthcare costs are moderated and healthcare quality goes up. And MCCD, the Medicare Coordinated Care Demo, and now this Comprehensive Primary Care initiative, both have turned out to be very disappointing in terms of what it's done for costs and what it's done for quality and what it's done for patient satisfaction with their experience of care. CPC is a 4-year trial. It's only 2 years underway. I talked about the 2-year report in my blog post. And despite the disappointing results, CMS is doubling down, if you will, with a new pilot program called CPC Plus. The two look very similar to one another. It's hard to imagine how CPC Plus is going to turn out to be any differently from the prior two demos.
So what's the plus, Jan? What's the plus that's added here for the new demo?
The plus is that it's going to be offering, as I understand, it's going to be offering 2 tracks. There's track 1 and track 2. In track 2, the physicians agree to take a haircut in some of the fees, but in exchange they get an even higher rate of payment for their care management and care coordination services. And the question is, downstream from this, what's going to be the impact on costs, and what's going to be the impact on quality?
Right, and as I understand it, there's some significant IT requirements for participation. I'm going to drop a link to some information about that in the comments.
Correct. In order, first of all, these sites have to volunteer to participate in this. This isn't something that's going to be dropped on the Medicare fee-for-service population. So these are going to be sites that are having a huge incentive, that believe in this, that want to do this, and in order to qualify, these sites will need to have a very, very robust electronic health record system, among other criteria.
So, gentlemen, if each of you were king, how would you address this continuing quality and cost conundrum? I mean, CMS continues to throw stuff against the wall. Thus far, most of it seems to be slithering down to the floor. What can we be doing differently?
Well,
go ahead, Joe.
I will defer to Jan to start.
You know, the question for me is that it seems to work in managed care Medicare settings. There is a good reputation in the managed care industry for these kinds of programs. For whatever reason, it's just not working in fee-for-service. And it may be that the care management and care coordination services are not necessarily additive, that they're synergistic to whatever else managed care provides. There are more incentives, I think. Networks are tighter. There are other utilization management activities usually going on, and if those are complemented with care coordination, it may be that that's what results in downstream savings for the managed care organizations. Unfortunately for CMS, I think 3 strikes and you're out, and if I were king, I would say this is really the last try at this, and if this doesn't work, CMS is going to have to try to find some other way to make fee-for-service and care coordination work, because it's does not seem to be happening here.
So, your positioning of this relative to other posts in the latest Health Wonk review, David, I think is right on point. Jason Shaffron, wrote a brief but excellent piece on pay for performance and is it doomed to fail? And it's sort of a broader topic than just fee for service versus ACOs versus Medicare Advantage, Medicaid Advantage, et cetera. But Jason outlined a fundamental flaw in pay for performance design, which is that you get, I'm going to quote here, the output of a rewarded service is guaranteed only in the most simple, I'm adding my own bold here, and unrealistic cases of pay for performance plans where a single quality metric is rewarded. When more than one service is rewarded, the change in the level of each rewarded service is ambiguous due to multitasking. In other words, if it's simple, it works. If it's not, it doesn't work. So, I'm just sort of reminded of the acronym Keep It Simple, Stupid, and not that any medical provider is. Of course, if they were, they wouldn't be medical providers. On the other hand, when you're dealing with all of these other drivers and you're trying to understand, okay, this is a Medicare patient, what am I supposed to be doing here as opposed to a private pay, as opposed to a liability or Medicaid or workers' comp or something else, how do I get all that, how do I keep all that stuff straight? And the answer is you can't. So therefore, you're going to defer to the thing that is the most simple. I guess in reading Jan's post and in listening to his expansion on that, I wonder if this is the death of fee-for-service for Medicare. So not that I would ever accuse any administration in Washington of being Machiavellian, but is this sort of a desire to show that fee-for-service just doesn't work? However, all of these good things we're doing, ACOs, medical homes, et cetera, does seem to work in a much more managed, much more tight, as you refer to it, network scenario. Then not going to do any more fee-for-service Medicare. And just one more comment on that. As a managed care guy, been in the network business, worked for an HMO consulting company 30 plus years ago, and it was all about the network. And when doctors signed up, they signed on the line that this is what they were going to do. Theoretically, you do that when you accept Medicare, but it's not like you do when you sign a contract with a private entity that's actually going to hold you to it. So David, Jan, I don't know what you think. Is this going to be sort of a virtuous result, and that we'll see the demise of fee-for-service Medicare, which is probably a good thing, and therefore better control of costs, or is this just sort of CMS is continuing to screw up?
Yeah, good. That's an excellent question, David. I'd be interested in your legal perspective on this. My personal feeling is that Medicare is very interested in risk transferring. It wants to transfer risk. It's an insurance company, and I think the numbers would suggest that it's not doing that good a job. And when it transfers risk to managed care organizations, good things can happen. Now the jury's still out on accountable care organizations and their ability to manage risk, but there's some potential there. But is the demise of Medicare, Joe, very interestingly, you hit the nail right on the head. Are they so bad managing risk that their demise is going to occur by a massive transfer of risk to other insurance companies or other big provider systems?
Yeah, I think there's a number of initiatives over the years have been dubbed, stealth single payer or stealth value-based care. There are a number of things that have been done where if you sort of think about the effects, you think, well, gee, this is a way in which the federal government is leveraging its influence here, much more broadly. I mean, Medicare pays for what, something under 50 million people, 50 million people's health care, and leveraging that influence plus the additional folks who are covered by other federal programs, federally paid and partner and whole, to the full U.S. population is a little difficult. So, but there are some sort of structural changes that Medicare can initiate in the care system because of its muscle, and that can play out much more broadly. I think interestingly, though, there's sort of a mix. I think there's more of an interplay, more of a dynamic. I mean, just as an example, the sort of ACO model, which is now seen as a Medicare model, started as a demonstration project within Medicare, was adopted much more broadly in the private sector, commercial payment sector, and then came back to be a sort of mainstream Medicare kind of provision. So there, I think the dynamic was shifted in an interesting way, where Medicare ended up as a follower rather than a leader. And the ACOs, like some of these other initiatives that we're talking about, are we wonder, are they really working? Are they really doing what they're supposed to do? Are they really performing at the level that they need to be in order to save all the billions and trillions of dollars that we need to save in order to right the ship? I want to turn to a couple of comments that we have coming in through the chat. Here's a perennial question. Why do we even have health insurance for primary care at all? It's like having auto insurance for oil and gas. And I guess I would sort of start the conversation off by saying, what we call health insurance isn't really insurance in the classic sense. It's a sort of prepayment for stuff that we know is going to happen, more or less, but we don't know exactly what pieces of healthcare we will need, but we all know that we will need some of it. Gentlemen, I don't know if you have some thoughts about,
So
how do
let
you
me
feel with payment for primary care? How do you think about that in the context of healthcare reimbursement, if not insurance per se?
with all due respect to the commenter, I don't think the analogy holds up. It's not about oil and gas. It's about tune-ups and spark plugs and changing your filters, etc.
Sure.
And so you're not going to pay. You don't have auto insurance to replace your motor because motor blew up because you didn't do the maintenance. You have it in case you have a crash. So I'm not sure the analogy holds up. With that said, I think the question is a valid one. And I think there's an economic reason for health insurers to have primary care paid for, which is that if primary care happens, then there's a chance that primary care providers will catch diseases, disorders, maladies, etc., before they become higher acuity and therefore dangerous. All the chronic diseases typically start out with some sort of acute episode, and if you're able to manage that at a primary care level, identify it before it becomes very significant, then I think you're in a much more care effective and cost effective model. So from an economic perspective, I think it's, as a former health insurance guy, you'd want to get those people into primary care quickly so that the asthmatics in my former home state of Connecticut, highest rate of asthma in the country, you can get those folks into treatment, et cetera. Folks who have depression or other issues, you can get them into treatment. And finally, there's a large population in our country that couldn't afford primary care, even if it was just $10, $15, $20 a visit. These folks are under Medicaid right now. So then you'd have to structure some sort of program for how do you get these people the primary care that they need paid for without them having to pay for it, which immediately comes back to insurance. So with that, I'll defer to Jan.
There was a lot of breakup, but it comes down, I think the question comes down to, do we finance this in a pay-as-you-go scheme, anticipating that there's going to be a budget and we just have to figure out what that budget is going to be? Or do we have an insurance mechanism that really results in a risk transfer, and we hold dollars in reserve for both known and unknown anticipated costs? And while those dollars are held in reserve, what do we do with them? Medicare really strikes me more as a pay-as-you-go system. They have a healthcare budget, if you will, whereas the big commercial insurers really run this in a risk transfer kind of way. I think there's much more flexibility, much more money around in an insurance environment to be able to do the things that you need to do to handle the healthcare needs of a population. But that doesn't necessarily mean that a pay-as-you-go system isn't going to work, and there are plenty of OECD countries that are highly developed that pay for healthcare in that particular way. There are advantages and disadvantages in both systems.
Yeah. I think as we're talking about this, I'm reminded of something I wrote a number of years ago in response to a piece. I think it was a health affairs issue on ACOs. I'm going to just share a link here. The idea that I was summarizing and reacting to here is that you could have, or we maybe ought to have, several different kinds of payment for healthcare services depending on the type of service. So this was talking about Jeff Goldsmith's approach to having risk-adjusted capitation payments for primary care, fee-for-service payments for emergency care and some diagnostic visits, and bundled severity-adjusted payments for episodes of specialty care. Because the payment and the payment incentive really ought to fit the broader incentives and the broader sort of cost structures that maybe apply to different kinds of care in different kinds of settings. And to me, that's always made a lot of sense. And we keep rolling out little piecemeal approaches, trying to deal with one corner of the world at a time. And maybe, we're just sort of doomed to do that forever. But it seems to me it'd be more helpful to take a more holistic view, even if it means doing different things in different places.
So the commenter, Mr. Chambo, great name, by the way, makes, I think, a very valid point that the current system doesn't allow enough time for primary care providers, to adequately address prevention and early detection efforts. And I would say the fee-for-service system, one can make that argument. Clearly, Medicare has done some things to try to increase compensation for primary care for E&M codes, which is definitely a step in the right direction. However, I think the point is valid in that if someone has 2 or 3 chronic conditions and you're trying to do as much as you can to improve that person's health, the quality measures that we were talking about earlier when referencing Jason Chaffron's point is that the quality measures are, as soon as you get beyond 1, it becomes really hard to get your arms around it. Therefore, maybe that's better in a vertically integrated delivery system where the provider system's totally integrated with the payer distribution system, that they can then transfer funds appropriately, pay for the right type of primary care, ensure that the diabetes eye tests and everything else is being done appropriately, and I realize this is a loaded word, rate or rank the doctors appropriately based on their ability to deliver the appropriate care for that individual, which may not fit into whatever methodology, formula, algorithm has been developed. And having worked for United Healthcare and other organizations in the past, they were uniquely unsuited to do that. And I think the vertically integrated delivery system with a payer appendage on it, if you will, is much better aligned to handle that.
Yep. We are coming to the bottom of the hour, and for those of you who have allotted 30 minutes to this experience, you are now free to go. Some of us will stick around and continue to talk, blab, if you will, and you can certainly follow the replay later. I'm going to drop a link here to the next blab, which will be in 2 weeks from today, and I hope that all of you will come back then to discuss. I think, to the extent you guys are interested in continuing this conversation for a bit, I'm happy to do so as well. I mean, what we're focusing on right now is really the perennial question, sort of one of the core questions. We've touched on a number of aspects of it. How many measures can we keep track of? How do we improve pay for performance through tracking performance measures? With the ACO system, we're talking about several dozen measures. Not all of them are even outcome measures. There's a lot of process measures. Do the process measures even help? I feel like I've been having this conversation for at least 10 years. I'd like to have 4 or 5 meta measures that would actually be predictive of quality and outcome. I don't know if we have any, or if that's sort of a futile hope. But that's something that we continue to think about and write about, I guess.
Well, I think this, just one comment on the whole blog thing. This is really, for me, been very educational. The last few of these that we've done, learned a heck of a lot more from people who know an awful lot from very different perspectives. So I really appreciate you taking the initiative to put this together, David.
Great. This has been great fun. Thank you both for joining again today, and hope to be able to continue to do this. And again, everyone who is participating in the live chat today, thank you for coming. Thank you for participating, and we hope to share more great blog posts with you in the future. Thank you all very much.
My pleasure.
See you next time.
Thanks, Mr. Chambo.
Yes, thanks, Mr. Chambo.